respectable members sitting on the stage, my radiological colleagues, ladies and gentlemen, Assalamu alaikum. My area of interest today's topic is what is interventional radiology. It is that subspecialty of the medicine which utilizes the imaging techniques like CT, MRI, ultrasound, fluoroscope procedures for two things. Number one, to guide and perform minimally invasive procedures, and for diagnosing and treating the diseases within the body without any surgery, without any anesthesia, and without normally admission to the hospital except a few hours in certain areas. So these are known as OBLs, office-based laboratory procedures. What does it involve? It involves the catheters, wires, or other small instruments through which tiny incisions or body openings are made for the procedures. It allows targeted interventions to manage various conditions, including vascular diseases and tumors. And it is going to replace, in most of the cases, the general surgical procedures where it can be started. Why interventional radiology required? Number one, because of the precision. Real-time imaging ensures accurate targeting of the affected areas, whether you are doing the ultrasound, which is the most real-time, or the fluoroscopy procedures or cath lab procedures, where you are seeing the things in real time. Minimally invasive, reduced trauma, quick recovery, and minimal scarring compared to open surgeries. And normally there is no anesthesia except conscious sedation mild for getting into these body areas. Hospital stay in most of the IR procedures, as I told you, they are OBL, office-based, and they don't require any overnight stay or maybe a few hours stay sometimes. It lowers the healthcare cost, enhances the patient convenience, and reduces the burden on healthcare facilities. Risk of complications is equally low. Bleeding, infections, and other surgical complications, and there is faster healing as compared to the surgical procedures. A brief introduction of cath lab, where we are providing the following services. Of all, the most relevant today's topic is uterine artery embolization, but there are other procedures like trans-arterial chemoembolization in the cases of liver cancers, prostate artery embolization, pelvic congestion syndrome, ladies with multiple gravida, persistent pain, lower abdomen. Everything looks okay, but you do the transvaginal ultrasound, you find the dilated tortuous veins which have got a hanging sensation and persistent pain over there. Ovaries are normal, uterus is normal. If the vein caliber is more than 4 millimeter, start thinking this lady has got the congestion syndrome because of the damage to the valves of the veins, the blood pools in the pelvis. Similarly, ERCP, which is done by the GIT specialist, and RFA, radiofrequency ablation, and by the for the varicose veins, and injection sclerotherapy. In case of uterine artery embolization, the main, after doing the thorough survey, there are 2-3 things which you kept in mind, which are contraindications like sarcoma, infective vascular diseases, and allergic to contrast. What is uterine artery embolization? It is an interventional radiological technique where the catheter is inserted through the normal femoral vein, femoral artery, up to the uterine artery at the level of the cervix. There are varieties of fibroids. We all know, and the most disturbing, they are the submucosal fibroids. The ladies have got persistent pain and persisting menorrhagia and discomfort, and sometimes these fibroids are associated with the adenomyosis. Similarly, if you find the large bulky uterus and you got the adenomyosis diagnosis, 50% they are associated with these fibroids. What are the modalities required to screen the patients? Ultrasound, and these days transvaginal ultrasound. The sensitivity can go more than 78% depending upon the high resolution, the operator, the color Doppler facilities, and the uterus is not very big. And by the help of color Doppler, even 3D ultrasound, you can diagnose much more accurately. But MR with contrast is required not to see only this fibroids, to see any associated pathology in the pelvis, like these fibroids and adenomyosis. They are associated with this endometriosis, to see the adnexal area. And you have this documented evidence, because ultrasound is reported by the operator, and whatever he or she says, if it's a matter of trust, you can trust the report, but I think still the document should be for any medical, legal and follow-up services as a baseline. MR is better. Sometimes you can do the CT scan if the patient has got MR contrast allergy or it is claustrophobia, you can do that. Here you can see the ultrasound. No doubt it's very discreet, very informative. You can see this cervical canal, you can see this endometrium, and there's a fundal fibroid which is pushing both the ends of both the horns of this endometrium. You can appreciate that. Similarly, on color Doppler, you can appreciate this is showing intense flow. Normally, the fibroids, they are myometrial fibroid, they are sparsity of blood flow, and mostly that is in the periphery. But you find the rich blood flow, please keep in mind it can have some sarcomatous changes. Very, very important. If it's growing enormously large and shows increased vascularity, before doing any procedures, you must do the DNC and verify the procedures. As I told you, this lady of 30 years who has got multiple fibroids on ultrasound confirmed by the MRI, you can appreciate this hypointense areas, and some of them are showing the cystic changes over there, suggesting this necrosis in the fibroids. Similarly, regarding the submucosal fibroid, if you look at this endometrium coming state, and after that is being split, and these days there's 3D ultrasound available, which takes you just a few seconds, and you can appreciate this on the opposite side. There's one dot here and the second dot there, and this automatically outlines the 3D. There you can appreciate on this side, there's a left horn of the endometrium and the right endometrium, and there's a large black area that's suggesting a submucosal fibroid. So it takes a few seconds by 3D ultrasound to know the diagnosis. The other important thing is adenomyosis. That was, actually I was asked about 4 days back by Dr. Frida to deliver a talk on this uterine. Basically, my presentation is taken by Dr. Khalid. That is CT brain. It will be much better as compared to me, inshallah ta'ala. Look at the opening word. The associated fibroids are 48%. So please, history of the patient is very, very important. They do have the menorrhagia, dysmenorrhea, bulky uterus symptoms, chronic pelvic pain, infertility, and obstetrical complications in case they become pregnant. So persistent pain, heaviness in the lower abdomen. Ultrasound, 78% is accuracy by ultrasound. But I can tell you it's better with the better operator, better machine, better color Doppler ultrasound. And let me assure you, always in pelvic pathologies, you must have transvaginal ultrasound. Don't depend on the abdominal ultrasound, because there are a lot of things which you can't see. And especially regarding the color Doppler ultrasound, the resolution of the color is much better on TVS as compared to the transabdominal ultrasound. But very important is operator dependent. That's why I always say MR is mandatory to document your findings. What do you look for in adenomyosis? Large heterogeneous myometrium. As I showed you in the previous ultrasound, the one thin line and peripheral hypocare. In this case, the total myometrium is heterogeneous, and you can find multiple tiny echogenic specks. These are basically the endometrial tissue invading the adjacent myometrium, and the surrounding tissue starts hyperplasia. So you can find hypocarias, you can find cystic areas, and the diagnostic sign these days, Venetian blind shadowing. That is bright echogenic shadows starting from the junction zone between the endometrium and myometrium, and at the periphery start seeing these shadows. If you find the shadows, that is one of the confirmation, that is a diagnostic sign for the adenomyosis. Number 2, you don't find the endometrium symmetrical center. In normal endometrium, the anterior half and the posterior half symmetrically have same share, but in this case, adenomyosis, the endometrium may be more on the posterior side, more on the anterior side, because the junction zone, it may be diffused adenomyosis, it may be focal adenomyosis. So in focal adenomyosis, the distinction between the myometrium and endometrium is bizarre. There's heterogeneous, the outlines are maybe smooth, and the diagnostic sign is increased vascularity at the periphery ureter. Medical management, as Dr. Frida told you, you are taking the NSAIDs, maybe hormonal, contraceptive medicine, IUCD, preterm, and SGA babies. If you get pregnant, the babies are going to have SGA small for gestational age, not IUGR. IUGR is asymmetrical growth, SGA is symmetrical, but smaller baby because of the pressure outside. And the ladies can have preterm deliveries, or they can develop the eclampsia. All these things, they can going to have it. Surgery, even I think today, I was reading an article, 70% of the adenomyosis diagnosed on the basis of the histopathology after surgery. But let me show you today, with good ultrasound, you can diagnose much more. Previously, it was 10% diagnosis on the ultrasound, and 70 to 80% was done on the histopathology. But I think now with the history of complaint of the patient, I always say to my colleagues, my younger colleagues, please, ultrasound is the one where you are very close to the patient, talk to the patient, take the history again and again, as you have just heard the previous speaker very candidly said, history of the patient, talk to the patient, take the details of the history of patient, उसकी history क्या, presentation क्या, उसकी age क्या, उसकी parity क्या है, उसे how does he have symptoms, वो पूछेंगे तो ultrasound बहुत ज़्यादा आपकी आसान हो जाएगी. No doubt, previously it used to be, even today, hysterectomy is the gold standard, or you can have wedge resection, or you can have myometrial excisions, or you can have the endometrial ablation, which is not having a very positive role in certain cases because there is a high rate of failure. So what else you can have? And that is where you can play a role as an interventional radiologist by the uterine artery embolization. You can do that. Look at this endometrium. There is a large bulky uterus. The normal uterus average size is less than 8 to 9 centimeter. The AP diameter is less than 4 centimeter. The transverse diameter is less than 5 to 6 centimeter. But you find a 10 centimeter, 11 centimeter bulky uterus, and you can see this endometrium, the bizarre pattern. The myometrium is not well defined. You can find some cystic area. You can find the bright echoes. If you find this bizarre pattern heterogeneous, that is most likely adenomyosis. You may diagnose it, but it is very important because 48%, 50% they have got associated myometrial fibroids, and sometimes 20% they have got the associated endometriosis. Why I am saying these two? Because the success rate depends on the associated pathologies. If you do have the endometriosis, the success for the long term may not be very good. For the short term, for 2 years or 3 years, pretty good. So you have to scan the details of the pelvis anatomy. For pelvic anatomy, do the transabdominal ultrasound and then do the localized area for the transabdominal ultrasound. Then you can appreciate this, that is cervix, that is endometrium. Look at the endometrium. This AP diameter is much more than this diameter. The distance from the serosa to the endometrium is small on this side, and on this side you can find the larger area. So that is the diagnostic sign. Even MRI, you can have the fibroid, but the junction zone has thickened maybe up to 3 centimeter. This just to review this article of, I think, 23, last year article. With the low rate of major complications in accordance with the Society of Interventional Radiology, classification and good success rate, uterine artery embolization should be proposed as an alternate for the patient who have failed medical therapy. And even those patients who have repeated surgeries and still there is complaints of the patient, history of bleeding because of the frozen pelvis over there, I think the alternative is uterine artery embolization. And this was the study carried out long-term and short-term regarding the symptoms of the patients, like ask question regarding the scoring, heavy menstrual bleeding, and uterine artery, this visual analog scale. There's approved, there's a marked recovery in the patients as compared to the before the symptoms and after this investigation. Similarly, there's a slide, uterine fibroid associated with this adenomyosis and health-related quality control questionnaire, significant decrease in the symptoms from 58 to 20. That means gross decrease in these symptoms and complaints of the patient. Similarly, increase in the quality of life from 40 to 83%. That means more than 50% the quality of life has improved because of decreased symptoms. What are the things you should check before the uterine artery investigations? Number one, clinical history of the examination. Full gynecological workup to help clarify etiology of symptoms which includes endometrial biopsy to exclude the malignancy if the lady is more than 45. That is very important. If you don't do this endometrial biopsy, do the TVS and see the endometrium. The normal endometrium in a post-menopausal woman should be less than 5.5 millimeter. If it is less than 5.5, maybe 2 millimeter, you can postpone this this biopsy because it is definitely low and there is no blood flow C. If you find endometrium more than 5.5 millimeter and there is increased vascularity and the irregular endometrium, please, unless surgery proves otherwise, this is definitely some malignant change taking place into it. Especially if this lady is more than 45, 50 years, it may be in the perimenopausal or postmenopausal. And simply you can do the pap smear for the local pathology over there. See if there is an allergic to the contrast or any medicines. Pregnancy test. Always, even the routine histosalpingography test should be preceded with the blood test for the pregnancy. Many times you have seen the patient coming for the histosalpingography. In my practice, I always do the routine complementary TVS before the procedure. For many reasons, one of them is if she is pregnant or not pregnant. Preparation, because some of the questions which are very normal questions, common questions, NPO should be there for at least about 6 hours. Folic catheter is passed for the patient comfort and to keep the blood empty. Prophylactic antibiotic is given. IV line is always. Even those of my colleagues who are doing simple biopsy procedures, there is a standard protocol. You must have the IV line, God forbid, to any complications during the procedure which can. And the patient normally go into vasovagal shocks. Mild sedation, and there is a continuous monitoring. Just to show this normal pelvic angiogram, you can see the aorta, you can see this anterior trunk of the right renal artery. What are the techniques of going into that? It's just a minimal percutaneous femoral artery approach. Normally on the right side the approach is taken. 4 to 5 phase catheter is inserted under fluoroscopic guidance up to uterine artery where the anterior division of the internal artery. Embolic agent is injected under the fluoroscopic control. All is done under the cath lab or the fluoroscopic control. Complete stasis is achieved in the uterine artery. Then you can appreciate this step by step initial pelvic DSA. You can see this increased contrast, vascularity you can appreciate in this, both right and left uterine. Normally it's a left dominant artery, but that is very important by doing the angiogram before you do the procedure is equally distributed both because normally they do the left and the right both. But if it is more on the left side, you can limit yourself. And the second thing you have to see if there's any communication between the ovaries and the uterine vessels so that you may not do damage to the ovarian vessels. And that is just after the contrast is given, you can appreciate this whole of this tumor is showing this blush, and that is basically embolization after that. And then you can appreciate on the right side similarly, and that is after this procedure, these vessels are totally almost blocked, and you can see the minimal outline of the proximal uterine artery, the rest of all is blocked totally. What are the outcomes of uterine artery embolization? Number one, for vaginal bleeding, alleviates need for the emergency-tectomy. So she was complaining of excessive bleeding, and now after this, the period stops, and then you can recur the periods after about 3 months. Within 3 to 4 months, they start the periods. Successful pregnancy after UE for postpartum hemorrhage, especially in those patients who have got this placenta increta and percreta. Similarly, fibroids, menorrhagia, dysmenorrhea, hemorrhagia improve in 70 to 95% of patients. Look at the results. And still you save uterus because those who are young and fertile want to conceive further, there is a high probability for the conception as well. Hospital stay is really more than 48 hours. What we have done so far, alhamdulillah, maybe a few hours or maximum overnight stay. Patient have back to work within 10 days. No post-laparotomy complications. Mean uterine volume reduction is 25 to 59%. So size of the uterus decreases, pain, heaviness, mass feelings, that is decreased. Fibroid volume reduction by 75% at the end of 6 months. The overall complication rate is less than 10% with the major complications 1 to 1.5%. Short-term outcome and long-term. Both menorrhagia and bulk-related symptoms like pain, pressure, and urinary symptoms, they are proved in 80 to 95% of patients. Short-term means in less than 1 year. Long-term uterine fibrinogen has been demonstrated to be effective compared to surgery in dermatoids at 5 years post-treatment. This is one of the very important cases I thought I must share you. uterine artery embolism, arteriovenous fistulas, arterial malformations. These unfortunate fistulas we have seen patients after having the abortions, having this DNC, after C-section, and even after myomectomy. So I always say when you find a lady with the history of abortion, even the DNC, and even if the lady is bleeding, two questions are very, very important. Please go and get the BTSC level. Never let the patient go home after DNC, BB DNC होगी अब तुम घर चले जाओ उसका BTSC please repeatedly follow कीजिए to avoid a risk of invasive mole. आपने DNC की, some of the tissue can go into the myometrium and you think you have done the job, the patient will keep on bleeding, patient has a high BTSC level, so please उसका BTSC level follow up जरूर रखिए unless it falls down. Second question is complication which we see these days quite frequently, that is arteriovenous malformations. No, arteriovenous fistulous communication. The patient bleed. This I'll share you unfortunate lady which last October, very important case please. 28 years young lady, married for a few months. She got married, she got pregnant in the second month of pregnancy, and after 8 weeks she started having spotting bleeding. So she was diagnosed as a case of missed abortion. And then she got the DNC. Unfortunately, DNC was done twice in the month of October. And she was still having PV bleeding, heavy bleeding, hemoglobin was going down every day, young girl. She came to us for a history of ultrasound. Khalisa, ये उसकी picture है ultrasound की. You can see these large vessels in the myometrium. You don't see myometrial vessels except at the periphery, small arcuate vessels. Endometrium इसकी ठीक है, well preserved endometrium, please, thin endometrium. No need of doing DNC. No need, just do the follow-up BTSC and get the scan done at a good place. If you look at this lady, she has thin endometrium, but she is bleeding profusely. If you do the color Doppler, grayscale, you can find the multiple channels within the uterus and outside the uterus. Always introduce the color Doppler. You introduce the color Doppler, you find very intense flow. But at the level of the endometrium, you don't see the blood flow. So that means nothing wrong in the RPOCs. RPOCs are predominant seen in the uterine cavity. Invasive mole can be seen in this myometrium, but invasive mole does not show any blood vessels at all. There is hypoechoic, there is heterogeneous area with increased vascularity. But once you find these channels, तो कान खड़े होने चाहिए कि इसको DNC की जरूरत है कि नहीं है. इसको DNC की जरूरत कतई नहीं थी, जबकि 2 दफा इसकी DNC हो गई. Look at the blood flow. The normal myometrium blood flow is less than 8 centimeter per second. Dr. Shahyar Sahab, the normal endometrium flow is 8 centimeter. Look at this blood flow. It's more than 30 centimeter. Very high flow and high diastolic. That means definitely the vascularity has increased. If you do the venous, it's showing the increased vascularities. That means there is arteriovenous fistulas, dilated tortuous vessels at the periphery. Normally वहाँ पे arcuate vessels होते हैं जो कि late age में जाके आपको prominent होते हैं. You see minimal blood flow and the velocity should not be more than 10 centimeter. You find the increased blood flow and then the CT was done. Look at the CT. There is increased vascularity in the periphery of the myometrium and it's going outside the myometrium. Look at this 3D surface shaded images. Look at the left internality. Look at the urinary, and this massively vasculature seen in the myometrium. So this was basically a case of arteriovenous fistular communication, which happens sometime in the post-DNC. And then the MRI was done at the same time. This showed multiple dilated tortuous blood vessels along the right lateral wall of the uterus and the left lateral wall of the uterus. We advised her to go for the urinary embolization. But Arfida, she went to one of our younger colleagues and she ended with the hysterectomy. Now look at the fate of the lady, young girl who was to be treated, and she would have survived the uterus, she would have normal regular cycles and she would conceive. So my take home message at this place is please after the DNC color Doppler किया जाए अच्छी जगह से तो उसका vessel note किया जाए. If she is bleeding, every DNC bleeding does not qualify for the repeat DNC, please. भले उसका BTSC level high हो, check the ultrasound, हो सकता है उसके myometrium में invasive mole चला गया हो. So that doesn't need DNC, that needs medical management like methotrexate or whatever. So this unfortunate lady ended up with a hysterectomy and she lost the uterus and she can't. You know the social impact of all these unfortunate areas. So my take-home message is, if you find a DNC done in a patient, the lady is bleeding profusely, please look for the endometrium. If the endometrium is okay, look for the surrounding. It might have hypokaria, which may miss mole. If not, if you find the blood vessel tortuous, do the color Doppler, see the arterial flow, see the venous flow. If it is below there, please, this needs. Sorry. Success rate of uterine artery embolization in the management of post-parietal arteriovenous malformations. Sorry. Sorry. All such patients are followed up to 6 months. Another article you can see, uterine artery embolization of uterine arteriovenous malformations. Similar to other medical therapies, the global success rate for embolization is 88%, presenting a low risk of adverse outcomes. Even in women with a later pregnancy, 77% had no complications. Now, very important question. This was a survey conducted after long-term and short-term follow-up from the patients regarding the symptom severity, how much they're better, concerns, activities, energy, mood, control, self-conscious, sexual functions, and health-related quality of life. And they all were showing far better, up to 80%. So the current recommendations is regarding UAE, uterine artery embolization, American College ACOG guidelines, patient fibroids may be given option for uterine artery embolization. Similarly, the NICE guidelines, uterine artery is an alternative to surgery. What does the patient have to say who underwent a uterine artery? This is one of the small videos.
अस्सलाम वालेकुम जी, मेरा नाम दहविश राशिद है और मेरी अनमोल डायग्नोस्टिक सेंटर में यूट्रीन आर्टरी एम्बोलाइजेशन की सर्जरी हुई। गाइनी ने मेरी बेसिकली रेफर किया था, मुझे फेब्रॉइड्स थे और मुझे पता नहीं था कि इसकी ट्रीटमेंट इतनी अच्छी यहाँ पे हो सकती है। एंड स्टेट ऑफ द आर्ट इक्विपमेंट यूज हुई थी मेरे पे। अब माशाल्लाह से मैं बिल्कुल रिकवर कर चुकी हूँ within a week's time. Our services have always been very excellent. Our Noor is the best choice for any treatment.
Madam Ataji, एक second. The take-home message is, it is an effective treatment method with a low risk of re-interventions, quick relief of fibro-related symptoms, highly significant improvement of quality of life, small fibroids, small means less than 10 centimeter, but I think even less than 6 centimeter. The smaller it is, the closer endometrium, the much better outcome is as compared to large. When the study says large means more than 10 centimeter. So this is the catheter available. I'm not doing the uterine embolization. My consultant, IS specialists who are dedicated, committed, they are doing it. I'm just providing services. I'm only interested in doing this varicose vein treatment, RFA. Ji, please. Thank you very much for hearing me that, please.